you all for coming. Usually I like to move around when I talk, but this time they had me tacked to this podium, and so because I have to move the slides. So the discussion or the talk today is about precision medicine, or more in specific, precision oncology. This is actually a discipline that's close to my heart. This is actually my area of interest in oncology, and approximately a year ago, we launched a program in precision oncology. Jen Haralka, who was instrumental in putting together this program, is also part of that. So that's what we're going to talk about. As we go through this presentation, feel free to stop me if you have any questions, any points you would like to raise. I'd be more than happy to discuss them as we go along. So this workshop or discussion will have these following components, which we will discuss, which is, of course, what is precision medicine, and what are the biomarkers, which are kind of the cornerstone of precision medicine, and how do we use them to develop a treatment plan, and also the targeted treatments we use in precision medicine, what they are. And also, last but not least, we'll be talking about genetic testing for inheritable cancers. This is slightly different from the earlier topics we have, but it's an important topic because sometimes it creates a confusion in what is genetic testing for cancer versus what is genomic testing for cancer, and we'll address that too as we go forward. And this has been medically reviewed, and there are some disclosures which we'll go through. So this was developed by the cancer support community and being supported by Bristol Myers Squibb, Foundation Medicine, and Genomic Health. And I myself don't have any relevant financial disclosures for this presentation, and I was not paid by any of the companies that support the development of this presentation. So, getting to the main part of this workshop, what is precision medicine? And there actually, if you Google this, you'll find a bunch of different definitions out there. To me, the definition here is very appropriate, I'd say. And also, this is not a very novel concept. It's been around actually for more than 100 years, where our experience when we go to see a physician, be it a common cold or some other illness, the idea is that you're diagnosed with a cold or whatever, and then you're prescribed a medication or a treatment that is specific to the diagnosis. And that but in the majority, it's actually the same, whether I go to see the doctor for a cold, or you, or somebody else, particularly for all adult patients, the treatments are going to be essentially the same. And the concept of precision medicine is, can we do a little bit more than that? Can we focus a little bit more on the actual individual sitting in front of the physician? And that essentially takes into account their environment, their lifestyle, also their biology. And what we mean by the biology is their genes. And so that is precision medicine as a broad definition. But when it comes to precision oncology, which is where my expertise is, my interest is, a lot of this precision and focus is on the genes, actually. So we need to know what do we mean by genes. Now, genes are, in some sense, our basic building block. It's kind of our blueprint. We get half of our genes from our mother and half from our father, and essentially they carry our code. And one of the popular sayings is development is part nature and part nurture. And the part that is nature is all essentially these genes. So these are basic molecules that are in our cells that carry the blueprint of who we are. So everything that comes after that, like the cells, the proteins, the connective tissue, the bones, the nerves, the neurons, all these cells are kind of manufactured or made according to the instructions that are coded into the DNA. And why is this important when it comes to cancer? It's important for any disease. But when it comes to cancer, the reason is something changes a normal cell into a cancer cell. That transformation, that change from a normal cell to a cancer cell happens in these building blocks, or the DNA, or the genes, as we call them. And that is why the precision oncology, to a great extent, is focused on identifying those genomic changes that transform a normal cell into a cancer cell, and using that knowledge then to tailor or develop a treatment to target the cancer. So, the next slide, the goal of precision medicine essentially is what I was talking about, which is taking those precise molecular aspects of each cancer and then developing a treatment plan. And until now, to a large extent, of cancer treatments, particularly advanced stage cancers, as many of you know, is primarily chemotherapy. Now, chemotherapy was developed in the turn of the 20th century, right after World War I. You know, when we started developing chemical weapons, we also figured out how to develop chemotherapy for cancer. So they are all closely tied together. And the idea of chemotherapy was to kill any cell that's growing rapidly, because the idea is cancer cells grow rapidly. In fact, the first set of cancers that we started using chemotherapy on were childhood leukemia, like children with leukemia and lymphomas, and these are particularly rapidly growing tumors. And that's the same principle we've applied to pretty much all the other cancers. So there's nothing precise or specific about it. And so we target any cell that grows fast, and that's the main reason why people lose hair while on chemotherapy, because our hair cells are constantly growing. And the same reason it kills cancer cells, it also kills your hair, and you lose also, you know, sometimes ulceration in the mouth. All of that happens because of that. And whereas in precision medicine, what we're trying to find is what's the difference between the normal cell and the cancer cell. And these differences between the normal cell and cancer cell can be different for different cancers, and also within the same cancer, what we call a lung cancer, which broadly encompasses all cancers that come from the lungs, can actually be different from each other, depending on the genomic changes we see. So that's basically when we figured out, Watson and Crick figured out the DNA, and then eventually we figured out cancer biology, we are now trying to move away from chemotherapy to developing more precise treatments for cancer. And so we come to this part of precision medicine where we're going to talk about biomarkers. Now, what are biomarkers and what are genes? Actually, biomarkers is an umbrella term which also encompasses the genes, because we know when we look for these markers of cancer that help us understand how these cells are different from normal cells, it's not just the genes we look at, just the DNA, because when we call the genes, what we call the genes are DNA molecules, but that's not the end of it. There is a lot more to the genome biology. There is something called RNA and then protein. And so we look at all of these things when we look for these biomarkers or markers for a cancer cell. So, like I said, and the testing that we do, we look for a broad panel of these markers when we test for these genomic changes in cancer. And right now, this biomarker testing is part of most cancer treatments, and it's rapidly expanding. And using that information, a physician might be able to develop a treatment plan, or also there are a few other things they can understand about the cancer, such as how aggressive the cancer is, or what we expect the cancer to, or how we expect the cancer to behave. And the way we do the testing is by either taking a sample of the tumor tissue itself, which is always the goal, which has always been the gold standard. Now the technology has progressed that in cancer patients we can also take the blood and test for some of these biomarkers. So there are different biomarkers. and they serve different purposes. And some of them have been around for a while. Some of them are more recent. For example, the ones that have been around for a while are these diagnostic biomarkers. People with colon cancer, pancreatic cancer, we've always been testing for some proteins in the blood that can tell us how the cancer, if the cancer cells are present, and also it can tell us just by the change in the level how well they're responding to treatment. And those that show if the cancer is present is what we call diagnostic biomarkers. It helps us to diagnose the cancer. Prognostic biomarkers, those are the ones that tell us how a cancer is, whether it's aggressive or is it something that is associated with better outcomes. Because we know, for example, in brain tumors, if a certain marker is present, those patients tend to live longer. Whereas patients who don't have the biomarker, their overall outcomes, even with chemotherapy treatments, are not that great. So that would be a prognostic biomarker. The last biomarker that we have here is a clinical biomarker, but the term I like to use for that is what we call a predictive biomarker. Because these biomarkers can predict if a particular treatment would work against this cancer. Now, this is where a lot of research is ongoing when it comes to precision oncology. We are trying to find markers to select a specific treatment against the cancer. And if present, you might be eligible, or the patient might be eligible for a targeted treatment. There are also other uses for biomarkers out there, which we already also talked about, like how aggressive the cancer could be, and also to see how well the cancer is responding to the treatment. Sometimes we can look at the levels of the biomarkers. If they go down while on treatment, that can tell you that the cancer is responding to the treatment. Whereas if it goes up, it might be a suggestion that the cancer is not under control anymore. So that's the other way it can help. And we have a list of biomarkers. These are well-established, well-known biomarkers for different types of cancers that we have here. And actually, this list is growing and exploding. And sometimes we have very good treatments to target these biomarkers, but we don't have a treatment for every one of them. So, for example, the markers that we have for breast cancer, the ER and PR, is the estrogen and progesterone receptors. Somebody having that would be responsive to hormonal manipulation to treat the cancer. And lung cancer, which is kind of my area of interest, is these EGFR, ALK, ROS, right? These have been around only for the last 10 years, but they've significantly changed how we treat lung cancer. Now, what used to be entirely treated with chemotherapy, these patients who have these markers are able to go on a pill, which, I finished training in oncology slightly over 10 years ago. At that point, a pill to treat a lung cancer was a pipe dream, but now that's a reality. And in fact, in certain types of lung cancers, more than 50% of those patients would be eligible for a pill treatment rather than chemotherapy. Now, there are other biomarkers. For example, we talked about, like in the brain, that we're talking about the NGMT, which was the marker I was talking about, which is a prognostic biomarker. We don't yet know how best to target these biomarkers with drugs yet, but they can give us a sense of how aggressive that tumor would be and how well the patient would possibly do with standard treatments. This is a very important.
Yeah. Is it true that there's not an infinite number of biomarkers, but a number that most of the population would fit into, based on that list that you had on the prior screen?
So, let me put it this way to answer your question. Every cancer patient has a biomarker, or biomarkers, I'd say. But we haven't figured them all out. So what we know for sure in every cancer patient is that something changes in the genome of the cell. Something has changed from a normal genome into an abnormal cancerous genome. So those changes are their markers of those cancers. But we don't know enough to understand what their role is and how we can target them and what they can predict for us. So that's basically it. So, yeah.
Do you have to know which kind of cancer you're targeting in order to do the test? Or do you have to test it? Okay.
That is helpful to know, and yes, it is important. But one thing we do identify with, as we do more research in this precision oncology is what we thought was one type of cancer is not one type of cancer anymore. For example, lung cancer. For example, when we go back to the lung cancer, for example, we have that marker EGFR and then ALK and ROS and all that. Now, we know that the lung cancer with EGFR marker is very different from the one before last, the BRAF marker. So these are different. And we also know sometimes, for example, this NTRK, any solid tumor marker that you see, is not specific to one type of cancer. It can be present across different cancers. And all those cancers with that NTRK or NTRK marker can respond to a specific drug that targets that medicine. So our previous classifications of cancer based on anatomy or where the cancer is located is being a little bit transformed. Yes, the location still matters, no question, but it's not absolute anymore. It can change depending on the genomics of the cancer. Does that answer your question?
I think so. Looking at breast cancer, for instance, do you have to locate a tumor and test the tumor, or is it more general?
For breast cancer, you can test a tumor from the breast, or if it metastasizes, say, to the bone or the liver. Not to the bone, that's always a bit difficult, to the liver or somewhere else. You can test that too. And you can find markers that you can use to treat against the cancer. The other one that I was talking about, you can also, in some cases, use the blood sample from the patient and look for those markers too, because cancer tends to, cancer DNA or even cancer cells, those spill into the blood circulation, and you can now, there's technology to find them, and you can use them to find the markers. So it doesn't have to be that location where the cancer began. You can go after and test tumors located elsewhere too. All right.
One last question. So the treatments for these that are listed up there, are they typically pre-made at the pharmaceutical company, or is that something that's mixed here?
Yes, it is. None of the treatments we have are, they're all part of traditional pharma, right? There's no such thing, at least with precision oncology, we don't have, at this point, any treatments outside of what's made by traditional pharmaceutical companies. And there's a reason for that, which is there's a lot of research that has to go in to be able to identify those markers and then to find the drug that goes with it. And last of all, that drug has to be proven safe and effective, which means clinical trials to be able to do that, right? So the resources are with pharmaceutical companies. So yes. And did I answer the other question?
Yes, you did.
Okay.
Thank you.
I'm just curious about the pill you mentioned with lung cancer. Could you just tell us what that pill is and which of the markers it responds to?
So the pill is specific to each of those markers. For example, in lung cancer, the EGFR, there are different, EGFR DK inhibitors. One of the common ones right now is called Tagrisso and or osimertinib that we use for EGFR. For ALK, there's like several medications, several pills that are available for now. Similarly for ROS, again, we have a couple of different pills available. So it all depends on the specific markers that you're looking at.
Thank you.
Okay. So the other part of biomarker testing, as anything in healthcare it is quite expensive. And now, though, insurance companies have been much more receptive to reimbursing for those tests. Some of these panels have been FDA approved, so they should be, they're much more readily reimbursed by insurance companies now. But still, there is a lot of distance we need to go when it comes to molecular testing. One being that the number of markers we keep looking for is constantly expanding. And the other thing also is we have these established markers. As you can see, that's only a handful, right? And that only impacts some patients. And even in those patients where you find these markers, these drugs control the cancer for some time, and then eventually it does progress. And when it does, we need to look for other options too. So there's a constant need for expanding biomarker panels and medications that can target them, and the clinical trials to keep developing them. So it is one of those things where, the insurance companies, the payers need to do a lot more than what they're doing right now. But it's much better than what it was a few years ago, I'd say. And obviously, when the patient talks to the physician about biomarker testing, genomic testing, it is a good question to ask. What is the cost of it? What is their out-of-pocket expectation? As many of these tests run into several $1,000s, as high as sometimes $10,000 to $15,000. There are some resources that's on this slide that you can look up on the cost of biomarker testing. Sometimes we are able to work with these companies to assist our patients such that their burden for doing the testing is minimized as much as possible. So thankfully, at least at St. Luke's, we have not been able to, we have been able to do biomarker testing in any patient that needed it without having to worry too much about costs. Most of the time, we were able to work, and Jen Havelka knows this very well. We've been able to work with the testing companies and able to find the assistance for those patients so that their burden is very much manageable. So the patient perspective of what precision oncology means. This is something you can read on the slide yourself. Talks about a lung cancer patient with ALK translocation, which was one of the markers that was up on the list. And the ALK marker, when it came about, there was just one drug available to target that drug marker, and it was quite toxic. And now there has been so many drugs, and some of them are much better tolerated. I have a patient of my own, a young lady, who we've been keeping her going for the last 8 years, and thankfully that's because each and every time we thought we were hitting an impasse, a clinical trial was completed and a new ALK inhibitor came out to the market. This happened almost 3 times, and each time we were running into some difficult situations. So there's been some significant progress, particularly in the ALK phase. Within the span of the last 5 years, there's now about 6, 7 drugs available in terms of ALK inhibitors. And that has been a game changer for many of our patients. In fact, when these drugs came on the market and they were found as an alternative to chemotherapy for these patients, we still were able to only control the disease for maybe a year at the most, and then they had to go on chemotherapy after. But now, many of our patients have not seen chemotherapy ever on this ALK, who have this ALK translocation. They've been able to stay on the targeted oral therapies for years now, almost like treating a chronic disease like diabetes or hypertension, of course. As our options run out, we are constantly looking to what next. But that's something that when I was training in oncology was almost unheard of, unbelievable. So that's how this has changed, how we take care of some of our lung cancer patients. So the biomarker testing, this is a little bit more knowledge on how this works. And one of the questions you raised was what are the targeted therapies for markers. So almost all of these targeted therapies are tied to a marker. So you need to, or the patient needs to test positive for that marker to be eligible for that drug. So there is something like a companion diagnostic. So I can't prescribe a targeted therapy for a patient if they don't have that companion biomarker. So something like osimertinib or alectinib that we use for ALK cannot be prescribed for a cancer patient that does not have the ALK marker or the EGFR marker. So that has to be done. And one of the terms I use for these markers is a predictive biomarker. So what that means is it predicts that in those patients using that particular drug can be very effective. But it's not 100% guarantee either. So there's always that unpredictability when it comes to cancer. And more than 80% of those patients, they respond to that drug, but there are a small number of patients, which we have seen in our own experience, that we were like excited, oh, we found this biomarker, now we're eligible for this oral agent and not chemotherapy, and it doesn't work as well or it doesn't do anything, and we have to rely on chemotherapy. So, of course, so what that means is it's nowhere near 100% perfect, but it's a lot better than existing chemotherapy options. So how does the targeted therapy work? We did talk about chemotherapy. Chemotherapy works essentially by killing cells that are rapidly growing, right? And targeted therapies can work in different ways. But the basic mechanism or the basic principle is this, that cancer cells are essentially our normal cells that are damaged, and somehow these cells, which should have normally been cleared from your body, once those cells are damaged, our body either tells them to repair themselves or to undergo what we call cell death or apoptosis. So they will be cleared out of the body. But for some reason, these cells survive, and they not only survive, they then start multiplying. And the way they do this, we talked about how they change the normal cell's genome, and what they do is they hijack some of the mechanisms that our normal cells use to grow and survive, and use it for their own survival. And they keep these mechanisms running. So it's kind of like, for example, once a human being has achieved the normal growth, we don't grow beyond that. Our bones don't grow beyond that. We reach a certain height, we don't grow. And that's because those cells have decided now our growth is enough, and they stop that. And so the growth mechanism goes into a shutdown mode. And why is that needed? It makes sense, right? You can't keep growing forever. You can't survive. You won't be in the ecosystem, an animal that needs to, that constantly grows cannot survive because its needs are going to be, cannot be satisfied by the environment, and it won't have a survival advantage. That species will die out very soon. So all of our cells kind of work in concert with each other. So the bones stop growing at some point, but certain cells have to replace themselves. For example, hair cells, which doesn't matter for us as much, but for animals it does, because that provides insulation from cold, protects them from the environment, and they have to constantly replace it. So your body has now figured out a mechanism where they work cooperatively. Your bones grow to a certain level, but your hair keeps constantly growing throughout your life so that you can have the protection from cold or other environmental issues. But in cancer cells, they don't work in concert with the rest of the body. They hijack these growth mechanisms and keep on growing, keep on surviving at the expense of the rest of the body. And those are the mechanisms which we're trying to find. And it's kind of like they have something like a switch turned on and never off, constantly keeps going. And targeted therapies essentially go after those on switches and see if we can shut them down. And that's how it works. And that can be in many different ways, either by stopping their growth advantage or stopping their blood supply or telling them to undergo cell death. It can be in different mechanisms, but the underlying principle is essentially the same. But again, cancer cells are very smart. They eventually figure out methods to adapt and survive and get through those mechanisms.
When you say a cancer cell is smart, I understand what you're saying, but I don't understand how a cancer cell could be smart.
Any living being is smart because it learns to survive. It's the instinct to survive, essentially. Anything that dies and can't adapt to the environment will not survive.
So when a cancer cell, if it is smart, when it comes under treatment, let's say with chemo and so forth, it'll send out tendrils or whatever you want to call it to form new cancers elsewhere in the body. Is that because it's smart?
So the smartness, you can call it whatever it is. You can call it smart. You can call it a survival advantage. The point I made about it being smart is that some of the best and brightest minds are trying to figure out how best to target a cancer cell that's so tiny. But we have not been very successful at that. There's still so much to be done. And that is why I made that point. But you can take it in any way you want. It's either a survival instinct or smartness or whatever it is. And it does it by different ways. For example, like you said, it can metastasize to other areas. That's one way it does that. Another way it can do it is it can rely on other growth mechanisms to survive than the ones that the targeted therapy is targeting. Other times, it's also, for example, when you have cancer, it's not just one cell, it's multiple cells, right? And some cells are more sensitive to the targeted therapies, and then there are cells that are, as they get exposed to the targeted therapy recurrently, they eventually figure out a way to find a resistance mechanism. So there are different ways they do that, and there is also the concept that we think there is something called a cancer stem cell. This is not being proven, which is kind of like this precursor cancer cell that hides within the tumor. There are a few of those that we never really target, and even though we kill the majority of the cancer cells with chemotherapy or targeted therapies, these cells still keep producing now a new lineage of cells that are more resistant against the treatments that we have come up with. So that's kind of how I personally understand how targeted therapy works, which is essentially to identify the mechanisms that give the growth advantage to the cancer cells and see if we can shut them off. So there are different types of targeted therapies, and right now they are broadly, two different types. Now, in fact, before I even began the talk, one of you were asking me about, when you say precision oncology, is it more like radiation being precise and more targeted against the tumor? And that is precision too. So that is one way of delivering precise therapies. Now, we know that there are newer forms of radiation and also newer methods to deliver radiation, which is much more targeted to the tumors, and that's a form of targeted therapy as well. But when it comes to medical oncology, the discipline that I practice, which essentially treats cancer patients by giving them medications, broadly targeted therapy falls under two categories. One, what we call small molecules. Small molecules are essentially anything that you can take in a pill form. Your common Tylenol or acetaminophen is a small molecule. All our blood pressure medicines that we take as a pill is a small molecule. So it's a simple chemical formula that you can manufacture, and that's one type of medications that we use as targeted therapies. The other one is what we call monoclonal antibodies. Now, monoclonal antibodies are very complex protein molecules. These are sort of based on the antibodies that we as human beings normally make. We all have an immune system, an important part of the immune system is what we call antibodies. These are protein molecules we develop in response to an infection. And we use those antibodies to target those infections. And scientists have kind of used that mechanism to develop treatments against many diseases, including cancer. So they identify a particular target in a cancer cell, and then they develop an antibody that's geared to specifically go after that protein marker in that cancer cell. And they've developed these antibodies in that fashion. So there are actually now several of those. In fact, I think the next slide, we have this targeted therapies, for example, here. So for the EGFR that we're talking about, those, the Qarziba and the Gelotrip are essentially small molecules. Those are all the pills that we use. And whereas for the HER2, which we're seeing, the Herceptin and Kadcyla, those are monoclonal antibodies that we use against cancer. So we use a mix of them. So we use both small molecules and monoclonal antibodies in our cancer treatment. One of the things I think which is also related to one of the questions that we were discussing about was tumor location. Does it matter when it comes to treatment? And the short answer is yes, but the more detailed answer is it's a bit more nuanced. We do know that cancers, just because of the anatomic location, are not different. There's a lot of similarities. And if we can identify some of those similarities, we can actually develop methods to target them. And one of the couple of things that we have recently identified and used to target cancer is one, what we call the MSI high, and the other one is the NTRK or NTRK gene fusion. So the MSI high stands for microsatellite instability. And what that means is certain tumors or the genome is a lot more damaged. They have a lot more mutations than others, gene mutations than others. And that happens because all of our cells have what we call DNA repair mechanisms. Anytime our DNA is damaged, there are mechanisms or systems that try to repair the DNA. And if those mechanisms are damaged, then the rest of the genome is vulnerable to damage from everything. And those cell DNAs are far more damaged than a cell with an intact DNA repair mechanism. And the MSI high, or microsatellite instability high, is actually a measure of a genome's ability to repair itself. So a tumor that's very unstable, or MSI, essentially has a lot more mutations and a lot more DNA damage. And if that is present, those tumors are sensitive to treatment with a monoclonal antibody called pembrolizumab or Keytruda. And that MSI high is not specific to one cancer. In fact, any solid tumor, if present, could be a colon cancer, could be a gastric cancer, could be a lung cancer, or even a brain tumor present, those patients respond to pembrolizumab. The NTRK gene fusion is different. When this data came out, it was with a lot of buzz and a lot of excitement in the oncology community, because once again, this was tumor agnostic in the sense it didn't matter where the tumor was located. If you had the NTRK fusion, you would respond to this drug called larotrectinib or Vitrakvi. But what was even more interesting is this was the first clinical trial where age was no bar, in the sense we had pediatric age patients, in fact infants, on the clinical trial, and we had 60 and 70-year-old patients as well. We never do that when it comes to medicine. The pediatric population is always separate. But in this particular study that was published in New England Journal of Medicine, we had infants, all age groups, essentially, and all kinds of tumors. And the benefit was seen across the board. It didn't matter what age, what tumor, but if they had the NTRK fusion, in most of them, in more than 80% of them, they benefited from that treatment. And we have an example here, which is the HER2 positive breast cancer. We touched on that. This is a protein marker that many of us are aware of because it's been around now for almost 20 years. This is something that every patient that has breast cancer gets tested for and should be tested for. And if present, they are eligible for treatment with monoclonal antibodies that target that protein. And Herceptin or trastuzumab was the only protein targeting that marker for a very long time, but now we have a few more monoclonal antibodies that target that protein. Also, there are some small molecule inhibitors to target them as well. As exciting as this field is, there are also limitations. We touched on them. One of those things is that even now, we use these treatments only in patients with advanced stage cancer, or what we would call stage 4, or at least the majority of them. The use of this in curing cancer is still limited. And when we use this in advanced stage cancer patients, we don't cure any of them. And also, it does not work in every one of them. You know, the majority of them it works, but there's always some patients in whom it is not effective, and so there is still work to be done. And eventually they do stop working, and then we have to find alternatives to come up with to treat the cancer. It's also an important topic, the cost. If you were asking me a question, any of these targeted therapies are available outside of traditional pharmaceuticals? The answer was no, which means these drugs are extremely expensive. But for those markers that we saw up there, those are all essentially FDA-approved markers and drugs. These are generally covered by insurance. And one of the things with precision oncology is that we always try to push our borders a little bit further, where we are trying to find other markers that we then try to have with drugs that may not necessarily be approved for them. But when we try that, that's when the trouble starts. Sometimes getting those drugs approved can be a problem. And so there's still, again, a lot of work to be done. Here at St. Luke's, one of the things we've been able to create was work with our specialty pharmacy, and we have a dedicated pharmacist for the precision oncology program, who has helped a lot of our patients get some of those drugs that are not necessarily approved for their cancer, but because of the genomics, there was an indication that it may work, and we were able to get those drugs for them. And in many of those cases, they've been quite effective for them. Last but not least, is the genetic testing. I was talking about what's genomic testing and what's genetic testing. When we say genetic, it usually refers to a single gene, and a genome actually encompasses the entire genome. One of you asked me the question, are there infinite number of biomarkers? The answer is no, because a human genome contains approximately about 20,000 genes, right? And then everything that comes off that RNA, the protein, is all based upon that. We have about 10,000 different iterations of the protein as well. So you don't have infinite biomarkers, but when it comes to cancer, you want to look at the entire genome to be able to find a marker that the cancer might use to survive and that you can target. But in genetic testing, that's more specific. What we are trying to find is the risk for inherited cancer. And obviously, we don't want to go looking for every possible cancer risk, and we kind of narrow it down to the possible risk in a patient, which is if they have a family history of breast cancer, or pancreatic cancer, or colon cancer, and there are some specific findings that put them at risk for those diseases, then we test for an individual gene or a panel of 2 or 3 genes to see if that marker is present. And so if it is present, then that can tell us that they are a higher risk for developing that cancer. And this is different from biomarkers. That does not tell us anything about how to treat the cancer. It tells us about their risk for cancer, and if they have the gene mutation, then there is a likelihood that they could pass it on to their children. And their siblings may also carry that gene as well. So it may have an implication beyond that individual. Whereas when we are looking at the cancer biomarkers, that implication is only for that particular individual because we're treating that specific cancer. And those biomarkers are not something you inherit. It's specific to the tumor. It is not something you tend to pass on to your children, or that's unlikely. Whereas these inherited markers are part of the entire body's genome, and they can have an impact, and you can, the patient can pass it on to their children as well. So the other name we use is genetic or germline testing. So these are in the, something you inherit, the patient inherits as right from the parents, right from when the fetus is formed. So that's why we call it germline. And also, just because you have a certain mutation, like for example, one of the well-known ones, or the BRCA1 or the BRCA1 mutation in breast cancer, doesn't automatically mean you're going to get breast cancer. And that's what this graph tries to illustrate. Now, if the x-axis is time and the y-axis is the risk for developing a particular cancer, normal people, all of us, whether you're a smoker, non-smoker, or healthier, not healthy, or other health issues, we are all at risk for developing cancer. So that's called the average risk, and that's what is shown in the blue line. But somebody with an inherited risk on top of the average risk has a higher risk to develop these cancers. That's what we see with the magenta line above that. So they're at a greater risk, but it's not a given that they will develop that cancer. We mentioned, like I mentioned before, not every cancer is considered inheritable. Some are. And even not all breast cancers, not all colon cancers are inheritable. There are some breast cancers, some colon cancers that are inheritable. Other cancers that we have seen with inherited risk commonly are ovarian, pancreatic, and uterine cancer. And it's only about 5 to 10% of all cancers we think are inheritable. So the vast majority of cancer, particularly adult cancers, are not considered to be inherited. Most of these are from environmental risk factors. So I was talking about the BRCA gene, and this is something that is one of the first inheritable risk factor for breast cancer. It was described several years ago. And not every breast cancer patient needs to have this tested. There are certain criteria. A younger patient, particularly somebody who's not attained menopause, would definitely need to be considered for testing for the BRCA gene. Also, if they had a strong family history. When we say a strong family history, it's usually a first-degree relative. First-degree relatives are parents, siblings, and children. So nieces and nephews are not always considered a strong risk, or grandparents again. Their impact on your risk profile is less than your first-degree relative. Certain specific types of breast cancer, like male breast cancer, if breast cancers do happen in men, it's a rare entity, but when it happens, inherited risk factors should be looked at. Also, certain ethnicities we need to look at. And if there is either a family history of this and you're concerned, obviously, discussing this with your physician or a genetics counselor would be quite helpful. And more importantly, they can also guide you on how to move forward with further testing, further surveillance, and also discussing with other family members as well. Yes, sir.
So the value statement about helping better treat a cancer does genetic testing tell you more or maybe additional information than what a biomarker would?
So these are two separate things. So where genetic testing comes into play, more importantly, is in prevention of cancer. So this is more important in somebody who does not have cancer right now.
Right.
And we're trying to use this information to prevent. So for example, let's take a hypothetical patient whose sister has breast cancer at the age of 45, and they are tested now for BRCA gene mutation. Both sisters have the same gene mutation. The impact of the BRCA is probably higher in the sibling that does not have the cancer, because now we need to figure out how best to take care of them and to monitor them, which would be, there are different ways you can go about this, which is, more frequent and, deeper surveillance for breast cancer is one. In other cases, we also talk about prophylactic mastectomy, basically to prevent, breast cancer from coming, essentially removal of the breast is what we do. So these are not actual cancer patients. Whereas the biomarker testing is a lung cancer patient or breast cancer patient coming in, and there you find a marker that's now going to change how we are going to treat those patients and kind of what kind of treatments we're going to use for them. So that's the difference between these two.
But the statement said it helps in treating advanced stages?
It can, and that is some markers that we are, this is still an area that we are still trying to understand. There are some markers that may guide some treatment as well, but this is not fully well understood. There are not a whole bunch of treatments available, and this comes from the fact that the BRCA gene that we are talking about can be a guide to use a certain type of treatment, particularly in breast cancer and ovarian cancer that we are working on right now. But that discipline still has some ways to go. And we have more resources on getting information on this testing. So we are pretty much at the end of this talk, and one of the other things we are going to be talking about is the Cancer Experience Registry. This is essentially a website where cancer patients or their caregivers can go on and register and share their experience going through cancer and cancer treatment. And that information obviously is very useful from both patient perspective and the provider perspective. Then there's this other website we have, which you can check out, lifeline.org. So that concludes my presentation. Yes, ma'am.
Are the slides going to be available for us on any website or something?
Yes, we can send them out from Gilda's Club as long as you leave me your information.
Oh, okay.
I'm happy to do that.
Oh, okay.
I'll send it out to everybody.
Thank you.
Yeah, absolutely.
Yes,
Stage 4 pancreatic cancer, I was tested for everything possible, 60-some markers, nothing. So precision medication or precision oncology treatment for me currently would be technically non-existent if I tested negative in all those areas.
So,
Is that correct?
Correct. The short answer is correct. Pancreatic cancer is one of the most difficult ones, particularly from the physician perspective. Also, I think cancers are not necessarily different cancers behave differently. Maybe our understanding of how we even look at the pancreatic cancer genome needs to change, right? Because when we do the genomic testing, we kind of extrapolate what we've used in lung and breast cancer. That's how we learn. We kind of bring those principles to find out what we can about other cancers, and then use the same knowledge to treat these cancers. And pancreatic cancer has been particularly tough from that perspective. But that said, you said you had a 60-gene panel. I'm not saying that we can find a marker, but now the panels have changed. 60 genes are almost, now there are panels that look at 600. There are also panels that actually look at the entire genome, the entire exome, all 20,000 genes. But I don't think you need all 20,000 genes sequenced in every case. But a more broader and deeper sequencing might identify other markers is one. And recently, there has been some data that there are about some pancreatic cancers, a small proportion of them, have similar to the BRCA gene that we talked about, type of marker, which in those patients, there is some early data that suggests a targeted therapy might be beneficial. Now, this is still very early phase. That data is still needs to be further tested and needs to go through trials before we can say yes, but there's still hope that we can figure this cancer out.
Question about diagnostic markers. One that men take is PSA. Are there any more reliable markers coming out for prostate cancer as well as colon cancer?
In terms of biomarkers, nothing immediately on the horizon right now. Now, in colon cancer, for one thing, we are coming up with stool tests rather than doing colonoscopies to catch them earlier. And the old version of these stool tests used to be just to look for blood, right? But now they're looking for different things, specific genomic markers for cancer too. So that is something that's happening, and that is still being tested. We're not there yet. In prostate cancer too, we're looking for such markers, but it has been taking a while to get that. But we've made some progress. In fact, recently there was a study out of MD Anderson where that company is going for an FDA approval for screening for different cancers, particularly including lung cancer, based on a blood test to identify or screen patients and catch the disease early on. So it's happening. More in colon cancer, lung cancer, prostate cancer. For some reason, we're still stuck on PSA. But research is happening there as well, but nothing immediately available.
So the future is really trying to find the cancer before it manifests itself in horrible ways, I guess.
Future is prevention, right? And so that we can prevent this from happening. And so that's one. Or, like you said, secondary prevention, which is you know it's happened, but you want to catch it really early and treat that. So yes, that's the twin goal going forward.
So where would you put an immunotherapy, like a panitumumab or something used for colon cancer, to actually target getting the chemo where it needs to be as opposed to a precision?
Right. It is precision too. Panitumumab, first of all, we know that panitumumab can be given for every colon cancer patient. You need to have the wild type KRAS, you need to have the KRAS or the BRAF gene mutation. So that's one. And so one of the things that we've been talking amongst the research community for oncology is smart chemotherapy. So even though chemotherapy is toxic and all that, I think it still has its place in the treatment of cancer. And again, selecting the right patient for the right treatment is not just about precision medicine, not just small molecules and monoclonal antibodies, also for chemotherapy as well. So by doing that, you can hopefully minimize side effects. So we know that some patients have much more higher risk of certain side effects from chemotherapy if they have certain markers. So there is a lot of research ongoing. Of course, it is something that still needs to go a long way before we can get there. But if done right, even chemotherapy can be part of, chemotherapy or panitumumab can be part of precision medicine too. And one thing we know, when chemotherapy is correctly chosen for a patient, they actually do feel better when it works right. And because if it shrinks the cancer down, patients feel better. It doesn't matter whether it's targeted therapy or chemotherapy. So we still have work to do on that side as well.
Dr.
Subramanian, we have a question from one of our audience members at Warrensburg. They would like to know, have there been improvements in brain cancer, such as glioblastomas with precision therapies?
The short answer is yes, but we still have a long way to go. Precision medicine has been a bit lopsided. Some cancers have benefited more so than others. Some of the ones that have really shown a lot of progress is lung cancer and melanoma. Brain cancer, yes, we have, in the last 5 to 10 years, we have more treatment options than what we've had. And we have some biomarkers, prognostic markers, but nothing like a predictive biomarker that you can test for and then develop a therapy based on that. We still have, work to be done when it comes to CNS tumors.
You mentioned a survey for patient experience. What is the goal of that?
Actually, I'm not very knowledgeable in that.
Okay.
Yeah, I can answer that. That's actually through Cancer Support Community. So it meets the CSC standard for clinical trial, but it's really trying to get to a point to elevate the patient voice. For all the way through clinical trials, for the drugs that's available, for oncologists to really understand what it's like, both for the caregiver and for the patient, and they have, specific cancer diagnostic ones, and then just general, but it's really it's a very long survey, but it's a chance to kind of really tell the story in a way that feels like your story is making an impact on the future decisions and treatment options that are coming out.
Okay.
Does that help?
Yeah, so it kind of goes hand in hand with Pivot.
Yeah.
Okay.
Exactly.
8 o'clock. However, the Joe and Go will stay open until 10 p.m.
Well, these are precision-targeted therapies. What do they target? Do they target the molecular makeup of the cell and interrupt it? Do they kill the cell, or do they just discombobulate it some way? Is that how it works?
Essentially all of that. So the mechanisms can be a little bit different. So one of the things we were talking about was immunotherapy, right? Where the immunotherapy works by recruiting your own immune system and guiding it against the cancer cell, so that essentially the immune system can then attack the cancer cell, destroy it, clear it, right? We were talking about something like osimertinib, EGFR driven drug. What that does is that particular, it's a small molecule, so it's able to enter the cancer cell and block a particular protein that it needs to continue to survive and grow and spread. So that's another way it does it. In other times, in other situations, it can sort of block the blood supply. As tumors grow, they need blood supply to grow, so they kind of recruit their own blood supply. There are medications that stop that. So essentially starve them off nutrition because they need the blood to survive, to get the nutrition and oxygen, and just choke them or starve them to death is another way that happens. Other times they block mechanisms that the cells need to repair themselves. And by blocking that, any living cell sustains damage as it lives and has to be able to repair itself. If it doesn't, then it dies. So it could be something that works in the surface of the cancer cell, it could be something that works inside of the cancer cell, or it could be something that works in the environment in which it lives. For example, recruiting the immune system or stopping the blood supply is working in the environment of the tumor cell.
Well, is it your job to match what's happening in that cell with that genetic makeup with the drug?
That is absolutely right. So that's where the biomarker testing comes into play. Okay. And you find the biomarker, and then you interpret that, and then you identify what would be the best match for that, and then you go with that.
I'm curious about the research. Who's funding the research? Is it government, or is it big pharma? Where does one look for that?
Well, so a lot of research is, there's a whole spectrum of research behind it. But broadly speaking, you can put it into 2 buckets. One is the basic science, where you're essentially sitting in a lab testing cancer cells against drugs, trying to identify the mechanisms within them, doing animal research with them, and that's usually done in all our research institutions funded by the government through the NIH and the National Cancer Institute. So most of this basic research is funded through the government. That's where, and that, even all these drugs that we see on the market today, the vast majority of them, the basic building blocks, were created out of government research. Once you have a molecule that looks promising, that's when private funding and pharma comes in, that they take to the next level and do the further research, and then take it to, conducting the human clinical trials. That's where the pharma research comes.
What's the pipeline now? I mean, how long is it taking for a promising drug to get out there?
That improved significantly. It used to take sometimes 10, 15 years to get some of these drugs out. In fact, I used to have a slide on targeted therapies. Now, if something looks very promising, the FDA has been quite aggressive in getting these drugs onto the general population. And they move sometimes within 2 to 3 years from early phase. We're talking about an early human study. I'm not talking about the molecule when it's in the lab. The first time it comes on to an early phase human study and then get to the market, 10 years ago, on average, it was 10 years, and nobody would be surprised by that. Now, you can sometimes see them out of the market within 2 years, 2 to 3 years.
I was surprised you said most of the funding is through the government.
For the basic research.
Basic research.
The lab research.
But the development of the drug itself is by the pharmaceutical companies.
Almost all of it.
And that's funded by cancer funds and things like that, just like we have $2 granddaughters with cystic fibrosis, and there's no money from the government for cystic fibrosis. It's all what we give through fundraising, charity fundraising.
So the answer is, the point you make, the answer is yes, So when it comes to research, there are two kinds of research. When a basic science researcher starts looking into something like this, they may not necessarily be answering a question regarding cystic fibrosis. They kind of look at the basic mechanism of how respiratory cell functions or develops. Along the way, you understand that better, and then you can use that knowledge to, to treat cystic fibrosis as well. And most of that research that happens is funded by the government. Now, that said, the funding is not always, it's not an equal distribution. Some diseases get more funding than others.
Oh, and I understand
obviously.
that. I just figured cancer, there's so many cancer fundraisers that's where the pharmaceutical companies are getting their money to do the research.
Pharmaceutical companies, particularly when it comes to cancer, they have their own private funding. They are well funded.
Okay.
They have their own,
More
at least the big pharma.
Why wasn't selling drugs? That's why you get the money.
So that's
Is there anything surprising to you, unexpected, serendipitous or something that's come out of all this target?
Every one of them has a bit of serendipity built into them. One of the stories I would say is, the EGFR that came about, in fact, before the biomarker came, the drug came to the market. And what we all knew was there were a few patients that responded very well to those drugs. The others didn't. And we didn't know about the biomarker. We gave it to every lung cancer patient. And in the vast majority of them, 90% of them, it failed miserably. And Harvard, Tom Lynch was the one who was behind that research, was treating a patient who was very well off, and he responded well. And then he was impressed that he gave Tom a chance to do a TV interview, to get on a TV interview and talk about this drug. And then another basic science researcher at Harvard saw the TV interview and called Tom Lynch and said, hey, I can maybe figure out why this drug works, serendipity, right? This wasn't science where a big conference of smart minds were working to figure out. It was just a Channel 5 news, and they figured it out, right? They worked together the next 3 years and found the biomarker. So there is a lot of that. And similarly for NTRK, when this marker came on board, they saw that the incidence or the prevalence in cancer was about 0.5%. And they thought, why would I even go after this marker? Most companies would say 0.5%, that population, that market is so small, why would I even do a drug development against it? But then somebody was smart enough to figure out, if I included every patient with cancer and looked them all and all ages, then I might find the market, and they did. And they were able to get the approval, and they are on the market right now. So yes, and there's always a little bit of serendipity when it comes to identifying these unique mechanisms and unique drugs.
Subramanian, we have another question from Warrensburg. They asked, if you are on a targeted therapy, can the cancer still mutate in the future and the target therapy not work anymore?
Yes, it can. The answer is yes.
Dr. Subramanian, can you share any speculation for the future of where you think we'll be in 5 or 10 years? Is there one particular kind of cancer that you think will see the most progress in treatment?
Right. I think some of the more common cancers will see tremendous progress, like lung cancer, breast cancer, similarly prostate cancer too. I think we'll continue to see a lot of progress. Never say never. I don't think we'll ever be able to cure a stage 4 lung cancer. I don't think that, at least not in my lifetime. I think I wouldn't see that. But what I do expect to see before I retire from this profession is that someday we'll be treating lung cancer like how we treat our high blood pressure patients or our diabetes patients, where we can, make this more like a chronic disease. They still need to be on treatment, but hopefully they can function at a far better level and less invasive treatment and have a much better lifespan than where they are right now.
I have one question. It just occurs to me that in lung cancer, something like 15% are not associated with smoking. Do you find in that population, the non-smoking related population, that you have more of a wealth of biomarkers?
True. In fact, the EGFR, ALK biomarkers, which are some of the first biomarkers to come in lung, was primarily present in people who never smoked. And so, yes, we do find that in them. But some of the newer markers are not necessarily always tied to tobacco smoking. So what we do understand is people who have never smoked and have lung cancer, their disease, I think, is a different disease from what we see in a tobacco smoker with lung cancer. And we still need to understand that better. I think that's where the key is in figuring out those treatments. And they do have, many of them, I think, have markers for targeted therapy, more so than smokers with lung cancer. And to answer your question about progress in cancer, I've been answering mostly from a solid tumor perspective, like lung cancer, breast cancer, and things of that nature. But liquid cancers or hematologic cancers like lymphomas and leukemias, in fact, we're also making tremendous strides there. Both certain types of leukemias and also myelomas, which is also another type of bone marrow cancer. I think that is also where we've made some tremendous progress. It used to be a very painful and very difficult disease to treat. It's almost becoming like a chronic disease at this point with